Hi everyone, hope you all are staying safe. So, in the last video, what we have discussed is we have discussed the virus structure of COVID-19. We have discussed some basic knowledge of this COVID-19 and the viral structure, the genome of the virus, and how it affects. Now we're heading towards the main part of the topic, that is how this virus, how the SARS-CoV-2 how it hijack the host machinery, that is how it hijacks the human machinery, human protein synthetic machinery, to make more of the viral proteins or the viral RNAs to infect the human cells, and how it results the pathogens, how it causes the disease in humans, that is either more severe disease or the mild one. So it depends on the pathogenicity of the viruses, and we will discuss the pathogenesis of the disease, and we'll also discuss more importantly, that is the transmission dynamics. So how it gets transmitted, that's very important, because there are most of the myths and misconceptions about the transmission dynamics of this COVID-19. So we will discuss in this video the transmission dynamics of COVID-19. After, we will discuss the pathogenesis, so how the virus enters into the human tissues, into the cells that cause the disease later on. So we will discuss it in detail. So first we will start with the viral entry, how the virus gets entry into the human tissues. So we'll discuss the viral entry. I was talking about viral entry. So if we look at the alveolar level, the cells which are making up the lining of the airways, that means there are two types of cells. That make up the lining of the airways. The first is type 1 pneumocytes, and the second one is type 2 pneumocytes. Okay, so this type 1, if we look this type 1 is, these are simple squamous epithelial cells that collectively make up 97% of alveolar epithelium. Okay, so type 1 pneumocytes form that these type 1 make up the 97% of alveolar epithelium. Okay, and these cells are very thin, and these form the blood gas barrier as well, which are adjacent to pulmonary capillary endothelium. If we are talking about this type 2, these are 97% with type 1 pneumocytes, and the rest 3% are make up by type 2 pneumocytes. So these type 2 pneumocytes, the important thing among them is they secrete DPPC. What is DPPC? This DPPC increases the surface tension of the lung. So this DPPC stands for dipalmitoyl phosphatidylcholine. So these decrease the surface tension of lungs and this DPPC also acts as the stem cells for alveolar epithelium, and these type 2 pneumocytes also proliferate in setting of lung inflammation and damage. When there is lung inflammation or there is lung damage, so these type 2 pneumocytes are those cells which proliferate in that case and regenerate the alveolar tissues. So these type 2 pneumocytes also act as the stem cells. So on this type 2, our concern here is only this type 2, because on this type 2 pneumocytes there is a transmembrane protein. There is one transmembrane protein which is known as ACE2. So on this type 2 cells, I will show you. So here it is, like type 2. This is type 2 pneumocytes. So if this is a cell For example, this is cell membrane, okay, and membrane, outer membrane, and this is transmembrane protein. So for example, there is one protein which is known as ACE2 protein. This is transmembrane protein, right? So this transmembrane protein is known as ACE2. On alveoli, this is present in the cells of pneumocytes, that is the cells which are the epithelial cells, okay, so which are found in alveoli and also intestinal epithelial cells, also, okay. This SARS-2, that means this COVID-19 virus, SARS-2 enters into the host cell. For example, this is host cell. This enters into the host cell by interacting with this ACE2. So that means this interacts with ACE2 receptors, and this first interacts it, and after that, what happens next? I'll show you what happens next to it. It is very simple. So here occurs, first of all, I will let you know that this ACE2, this is implicated. We're actually finding it somewhere in the RAS system, that is renin angiotensin aldosterone system. In this RAS system, we are finding also ACE2, and also in the pathogenesis of hypertension. That means in pathogenesis of hypertension and RAS system, ACE2 is also implicated there. But to make sure, to avoid the confusion, there are two terms, two proteins, ACE and ACE2. These are two different. This is not just one. These are two different, ACE and ACE2. So I will briefly tell you. This ACE converts in a RAS system, angiotensin first gets converted into angiotensin second. Angiotensin second is potent vasoconstrictor. This is vasoconstrictor. So that is angiotensin second. This ACE, only ACE, this converts this angiotensin first into angiotensin second, that is ACE. But ACE2, this angiotensin second, when gets converted back into angiotensin 1,7, this reaction is catalyzed by ACE2. So ACE2 in simple terms decreases this potent vasoconstrictor, that means decreases angiotensin second, and the same time this produces primary vasodilatory, that is this one. This is vasodilatory agent, or we can say vasodilator. Okay, so this decreases the vasoconstrictor and increases the vasodilatory agent. ACE2 is also implicated. So to make you understand this thing and to get to know these important things, this ACE2, where it is also expressed. So ACE2 is also expressed in intestinal epithelium. It is in intestinal epithelium. It is also found. It is also found in nasal goblets. ACE2 is also found in secretory cells. It is also found in olfactory epithelium, and it's also found in stem cells, right? So now there is one mechanism how this SARS enters into, so that is that's what our topic is, like how it hijacks our system, how it hijacks our immune system, or we can say how it hijacks the host machinery. So here I will make you understand this thing. This is, for example, I'll make you understand it in a very simple way. First of all, you would have learned one thing. you might have remember one thing that I have told you earlier, the virus structure. There are four structures are there. That means four domains are there in the virus structure mostly that we are reading. That is like envelope is there, membrane is there, and membrane, envelope, and one most important one is nucleic acid, and one is most important, that is spike protein. Why it is important? Because only spike protein is responsible for the virus infectivity, right? Infectivity means that is it also there occurs a change in the viral protein. So when viral protein means in this spike protein there happens a change in spike protein that facilitates the entry of this SARS-CoV-2 into the cell. So how it happens? This I can show you. So if for example we can make here a rough diagram. For example, this is our cell. Okay, so this is a cell membrane, and outside here somewhere a SARS particle has come. So this is, for example, the structure. This is a very rough structure of SARS, because we have already discussed the virus structure of SARS. For example, this is SARS. Now, how it enters this plasma membrane, how this SARS enters into the cell. First, I told you that, for example, this is spike protein. That means as it is spike. So, in order to know this, so binding up this spike protein, that means SARS-CoV-2. To here, I told you there is one protein that is known as ACE2 protein. Now, binding up this SARS to ACE2 causes a conformational change in this spike protein of the SARS-CoV-2. So, when there occurs a change in viral S protein, this allows the proteolytic digestion of this viral protein by host cell protease. So there is also host cell protease. That means this is a human cell. So there is one protease, and that protease I will tell you here what is that protease. For example, here we can say this is one protease, and this protease I will tell you the name of this protease is TMPRSS2. The name of the protease, host cell protease, host cell, and the name of this protein is host cell. This is host cell protease TMPRSS2. So what happens after that? So this causes the digestion of this viral protein. What is this now? So this is a simple serine protease, because it has a serine domain as well on the host cell membrane, that primers this serine protease. That means what it causes. So this primers the viral S protein. This primes this viral S protein by cleaving it, and allows the fusion of this viral protein, this viral membrane to the host cell membrane. How? For example, this interacts first with this ACE2. So this is ACE2 receptor, and this is protease. When this virus protein binds with the ACE2 receptor, for example here it comes in interaction with this, and there is the action of this protease, serine protease TMPRSS2. It causes the cleavage of this protein and help us also also facilitate us the fusion of this viral membrane with the host cell membrane. For example, like this comes inside the host cell. The membrane of both this and this becomes fused. This and this membrane becomes fused. Okay, this is the one thing. Now, when it comes in contact with this, what happens after that? There is actually the two pathways. I'll show you later in this case how it enters now inside. Now these two membranes are now fused. First thing that I would like to show you in this, what are the domains of this serine protease. One is it has, first I can say there is a type 2 transmembrane domain. Second, in this protease there is receptor class A domain. Third, in it is a scavenger receptor cysteine rich domain, and the fourth one here is that I have already mentioned is serine protease domain. So these are the four domains of this TMPRSS2. So Now what happens, this SARS-2 uses SARS-CoV-2 and CoV also. So that means both SARS strains use this ACE2 receptor for entry, and that entry is then primed by this protease, that is a proteolytic enzyme we can say, or the serine protease for the entry. So this is then primed by this. And here if we deeply see this one, if we inhibit this protease, by some chemicals, by some drugs, for example there is one misolite drug is there. So if we inhibit the activity of TMPRSS2, will this viral protein enter inside the cell? No, big no, because the activity here, because that is not get fostering, that is not get cleaved. Second thing, there would be no the conformational change in it. The third thing is it is not primed to get entry into the host cell. So once the viral protein is not inside the host cell, how it can use the host cell machinery to produce more virus? So that is impossible. So the one drug that can target this TMPRS are also in the pipeline, and some drugs are also used to inhibit the activity of TMPRSS2, but the clinical utility of those drugs is like under trial. So that is a different topic that we will see at. But now these two membranes are together. Okay, now how this enter inside this cell and makes it as viral protein, that means makes this host machinery its own. So there are two pathways. There are two pathways. First is endocytic pathway, and second one is non-endocytotic cell surface entry. So here by this pathway, so this is for example SARS-CoV-2 virion. So for example this is the spikes of it, spike protein of it. This is for example the cell membrane, host cell membrane. So there is one receptor of it which interacts with this spike protein. So this spike protein interacts with this receptor. This receptor is known as ACE2, as I already mentioned. So when these two are getting fused, this is a cell surface protein, a receptor we can say. Now there is the activity of TMPRSS2, that is proteolytic enzyme or enzyme. So it cleaves so these two are now in close contact, these two membranes, and after that, as we know, they form a vesicle, and this is the endocytosis. So endocytosis, through the endocytosis pathway, so this whole complex forms their depression and comes inside the cytosol like this. So now the whole complex is like, this is a virion, we can say this is a virion, and this is vesicle, endocytic vesicle. So this endocytic vesicle, after that it forms like this. So this is again inside this vesicle there is a virion, as we know, but in the cytosol this vesicle releases this RNA, we can say, that is a single stranded RNA into the cytosol. So it releases the RNA inside the cytosol, right? So till here there is the activity of ACE2, there is activity of TMPRSS2 that facilitates the entry of it inside the cell through endocytotic pathway, and after that there is one more thing, that is the virion gets released. The virion is releasing its RNA into the cytosol. Once the RNA gets released, now this is the RNA. What happens to this RNA now inside the cytosol? That means inside the cell, that means inside the host cell. Okay, now as we know, first thing that this RNA is positive sense as I already mentioned. So it essentially serves, it is a positive, so it is RNA and it is positive sense, so it is essentially serves as a mRNA. Okay, if it serves as an RNA, so it can directly translate it immediately into the viral protein, right? Viral protein, but by using the host cell machinery, not his own machinery, but by using the endogenous cell machinery, that means the host cell machinery. Second point, some of these proteins which are already formed by this virus by using this host cell machinery, some proteins form also the replication complex. These form the replication complex. Some are translated into proteins, and some of these proteins form the replication complex. What is the replication? So these form more RNA, and when there are more RNA, those more RNA also gets translated into the viral proteins by the endocytic cell machinery. Same as in the first case. Okay. Because to produce more RNA with the viral RNA-based RNA polymerase, because it uses the genetic material of its own, that means virus uses its own genetic material by using the host cell machinery to build up the proteins. So that means it builds up more SARS-CoV, so there will be large accumulation of SARS-CoV-2 virions. Right, so these gets accumulated, either RNA of this is also gets accumulated, and the proteins or viral proteins also gets accumulated inside the cytoplasm. And these accumulated proteins are these accumulated RNAs which are later on translated into the viral proteins. These are also gets assembled into the new virion. So it takes the shape of new virion. How? So here, if we are taking this virion, what happens to this virion later? So this RNA, I am looking here, this is RNA. So it, after that, there are two pathways. Either it goes directly into the cell machinery, that means on the ribosomes. Okay. For example, this is Golgi apparatus, and this is the endoplasmic reticulum. There are ribosomes, that means protein cells in the machinery. So after that, there is a sorting of these proteins by the Golgi apparatus, and on ribosomes, the proteins are viral proteins are making. After that, Golgi apparatus sorting these proteins, sorting the proteins to the destinations. So that means there is a formation of new vesicle with new virion. That means a new viral protein. So this whole complex is now with a viral load. That means the viral proteins. Once this is formed, now it has to go out of the cell to infect the adjacent cell, to infect the neighboring cell. So how? Through the process of exocytosis, simply. So this protein making machinery is, this is the protein making. Now the protein is already made, protein is there. So what will happen now? So this is again, for example, the cell membrane, the host cell membrane. So now this protein will get released from this, like this. There will be a bump like depression in this membrane, and this whole complex takes the form of new virion, like here, and this new virion gets released from the cell and infects the adjacent cells the same way as it has infected this first cell. So this is how this SARS-CoV-2 hijacks the host cell machinery by making it its own viral proteins, and then infects and then makes abundant of viral proteins and viral RNAs, and which are then released back to infect the neighboring or adjacent cells of the host. Okay, so this is. So here is one thing that is the reason, like there is an involvement of like host effectors, how the host effectors are mediating the virus infection. That host effectors, like how the host effectors are helping this virus to make the viral proteins rather than its own proteins. So it is making the viral proteins. How it helps us? So there is the involvement of host effectors mediating the virus infection, which have been reported, and that's the aim of identify the new antiviral drugs, drug targets, which are, again, I can say these are also in the pipeline, because if they would have been already mentioned, or they would have been already past the clinical trial, then we would have definitely not in the suffering this the pandemic, because there would already have been any medicine. But all these drugs are in. Now we will discuss an important thing where there are most of these misconceptions and myths I'm hearing from all my friends, sometimes from other people. Also, there are most of the myths and misconceptions regarding the transmission, how this COVID-19 are getting transmitted from the person to person, or from how it gets transmitted. That's a simple thing, how it gets transmitted. So, I would like to talk about this thing, the transmission dynamics of this COVID-19. So, first of all, we'll see this. This is that we all of know that this gets transmitted through respiratory droplets. Now, there are types of respiratory droplets. Which respiratory droplets are mainly causing the transmission, which are involved in the transmission of this COVID-19? There are two types of respiratory droplets, which are like that I will discuss all these things in the transmission part. And other routes of transmission also, like the virus contamination of the common objects, like object contaminated by the viruses, for example, like that. And the aerosolization in the confined space are from the asymptomatic. That is the very the dangerous thing, and also the asymptomatic infected persons. That's a very dangerous and it's a very critical situation, because the person who are very asymptomatic, they don't know whether they have the symptoms or whether they are infected or not, because the symptoms are not visible there. They are not experiencing any symptoms, but they are getting the infected. They are already infected, and they are infecting the other people as well, because they don't know that they are infected. So there is that is the reason that we are taking proper care of ourselves. We are that's the the guidelines are to stay inside, don't go outside, because you don't know who is infected, who is not infected. Because recently we have gotten news that in Kashmir there are 78% of people who are asymptomatic. There are no symptoms visible, but they are infected. There are 78% of people are like that. So in most other states also, there are also like asymptomatic individuals are there. Now we'll see these respiratory droplets. How these respiratory droplets can be generated. So these can be generated by sneezing, by coughing, by talking. Right, these are the main things how these respiratory droplets can be generated. By sneezing, there can be 40,000 droplets per minute we can generate. 40,000 droplets by sneezing. Now, if we talk about the coughing, there are 3,000 droplets per minute we can generate, and by talking, there are just 600 droplets per minute that we can generate. So the proper precautions, the proper care, proper things, that the use of masks and use of the bent elbows when you are sneezing or when you are coughing. So this is very important when you are sneezing or when you are coughing. Only in that purpose is it very important, because the other person whom you are talking with, to prevent them from getting infection, or to prevent the other people who are surrounding you, to prevent them from getting infection. So the use of masks is very important here. But the mask should not be the cloth masks that we are seeing at the home, because that is of no use. That is, use the masks either the masks should be the filtrate masks, like it should be the filter masks like N95 or you can say 3M, but don't use cloth masks. Don't use sponge masks, is also of no use. I'm strongly telling you, it's of no use, these sponge masks and cloth masks. No, adversely it can impact back to you, like it can get you more you can get some more infection from yourself when you are using the cloth masks, because that is not the filtrated mask. When you are sneezing, when you are coughing, and your whole the bacteria who are coming out from yourself only, they are again you are breathing in again those bacteria from those. So it is not filtrating anything. It's not filtrating. So avoid use the cloth masks. So second thing what you can use is how these droplets are produced. So these droplets can also be produced by medical procedures like intubation, like bronchoscopy also, and use of oxygen masks and nebulizers, or we can say nebulizers. Okay, now the droplets are also like larger droplets and smaller droplets. Larger droplets means the size when it is more than 60 microns. When the size of droplets is more than 60 microns, that means these droplets tend to spread around, these larger droplets tend to spread around 1 meter. That means 3 feet almost. So these droplets, larger droplets, spread about 1 meter, that means 3 feet, and thus it requires the droplet precautions. Okay. Now again there are smaller droplets. Smaller droplets tend to spread further and require airborne precautions. So for example, when there is larger droplets, so there's a weight. This weight tends to spread like only for 3 feet, only for 1 meter or 3 feet. But when there is smaller droplets, so there is less weight than the larger droplets. Then this larger droplet, there is less weight. Less weight means they tend to spread further. That means away from 3 feet or 1 meter away. So there is a requirement of airborne precautions. So that means, but luckily here the thing is this SARS-CoV-2 and SARS-CoV also. So these spread through larger droplets. Important. These spread through larger droplets. So this, in order to don't believe the myth that this COVID-19 is an airborne disease. It's not the airborne disease. It is a droplet. It is a droplet precaution should be taken care of. So this is not airborne disease because it is spreading by larger droplets. So only droplet precautions are required. No airborne. It is not airborne. It cannot stay in the air for so long. No, nothing. So the previous work, if we are, so I can say like the previous work that we are studying from the previous work, like coronaviruses, suggest that the disinfectants like we are having in the house, for example, some cleaning products are there at our homes that we are using to clean some glasses, wooden objects and other things. So there is also some surface disinfectants. So the disinfectants which has at least 70% ethanol. It is actually recommended 61 to 70% ethanol, but usually 70% ethanol or 0.5% hydrogen peroxide when there is found. So the cleaning product is which has 70% ethanol or 0.5% hydrogen peroxide, they can inactivate the coronaviruses. That are present on the surface. So don't eat it, don't drink it. So this is like inactivate the coronaviruses only which are present on the surface. Second thing is that is actually the ability of SARS-CoV to infect the intestinal epithelium lines. Viral RNAs has been detected in almost like 25 to 55% of stool samples. This RNA has been detected in COVID-19 patients. So this viral RNA has also been detected in stool samples, in rectal swabs. In stool samples and rectal swabs, it has been detected even after this oral or nasopharyngeal swabs become negative. When this was negative and still this RNA has been detected in stool or rectal swab, so it is very difficult. So it is a very dangerous virus. So those data requires the the possibility of fecal. So there is a we are forced to think about the fecal oral transmission of this COVID-19. Fecal oral transmission. Maybe it may be there, but we are not sure about it. The second thing is like SARS-CoV-2, which is also been isolated from the blood, but from the very rare patients also. So blood, from stool, from rectal swabs, from oral or nasopharyngeal swabs. So this has been detected in blood also. It has been detected, but in very rare patients, and it has been detected from the conjunctiva of eyes. So that's why the precautions are like don't touch your eyes, mouth, or don't touch your nose, and. So, but till now, this RNA, this viral RNA has not been detected in the urine. Till yet. Another more fortunate thing is, till date, this COVID-19 is not detected in case, it has not impacted adversely the pregnancy. No. But the more fortunate thing is that this SARS has not been detected in AF samples, that is amniotic fluid samples. It has not been detected in cord blood. It has not been detected in neonatal throat swabs, and it has also not been detected in breast milk. So that is luckily, so the generation is not getting affected, in the new generation or neonates are not getting affected in any way. And the most important thing is that the neonates who are born to, if the mother is COVID-19 positive, if the mother is COVID-19, if the mother is COVID-19 positive, but the neonates who are born to this COVID-19 positive mother, they are acquiring the IgG antibody transplacentally. They are acquiring the IgG, and IgM, but the mechanism is not known. They are also acquiring the IgM antibodies against the disease. So that means IgG and IgM antibody has also been acquired by the neonates who are born to COVID-19 mothers, COVID-19 pregnant mothers. This is the thing. So the another thing is viral load. You can say viral load. So what this viral load can be the positive multiple of 1 to 7 days before the symptoms onset. That means it peaks around the time of the symptom. So when the time of the symptom onset, we can say, so when there is a symptoms are getting onset, so the viral load is very high. That's at the peak. So that suggests the significant viral load before some person knows that he or she is getting infected, he may be infected. Now the incubation period. What is that incubation period? That is the exposure from the exposure to the virus till the onset of the symptoms. That period is known as incubation period. And the current incubation period ranges from 1 to 14 days in COVID-19. Okay, so current incubation period of the disease is 1 to 14 days, with median is 5 days, with 95th percentile of 12 days. That is similar to SARS-CoV. Okay, so detection of RNA in patients but see, this incubation period is usually 1 to 14 days, median with 5 days, and 95th percentile of 12 days. But the detection of this viral RNA in patients at about 20th day, at about 20th day of infection, or as long as 37th day. This suggests the potential of prolonged viral. So this suggests the potential of prolonged virus shedding. So virus is taking too long to shed. So there, by seeing the scenario of this 20 days and 37th day, so this suggested when there is the increased severity of disease or cases, so that is associated with higher viral loads and larger duration of viral shedding. That means increased viral load and larger duration of viral shedding is responsible for increased severity of disease. So increased severity of disease is due to increased viral load and large duration of viral shedding. Right. So these are two things. Now this shedding usually occurs, that I will tell you that this shedding usually occurs at least 24 to 48 hours before symptoms onset. But the incubation period, if we will see what makes this SARS very, very, very difficult to contain, is two things. That is, first, the incubation period, and when this incubation period is combined with transmission from, I already mentioned, from asymptomatic people, that means from asymptomatic hosts. So this incubation period, when combined with transmission from asymptomatic hosts, this makes the SARS-CoV-2 very this makes this particularly it makes it very difficult to contain till date because of these two things. So this was about the the transmission dynamics of this COVID-19. So we have we have discussed today the pathogenesis of COVID-19 and the transmission dynamics of COVID-19, and we are now aware about the transmission dynamics also. That is very important. And in the next video we will see the diagnosis of the various approaches of the diagnosis of the COVID-19, the management of how we are managing this COVID-19, and other things. We'll see side by side by discussing these topics. Till then, stay safe, stay home, and take care of yourself properly. Thank you very much.